Welcome to the Fine Lecture Series. On behalf of the Perinatology Research Branch of NICHD and the National Institutes of Health, my name is Lami Yo, and I am one of the developers of Fine. Before we begin, we encourage you to subscribe to our YouTube channel to learn more about fetal intelligent navigation echocardiography, or Fine, its features, and practical implementation in the clinical setting. More educational presentations will be forthcoming. In the next series of teaching presentations, we will now switch to a different but very crucial modality in fetal cardiac imaging. The theory of the Doppler effect is named after Christian Andreas Doppler, shown here, who lived from 1803 to 1853. He was an Austrian mathematician and physicist whose work has laid the foundations for modern ultrasonography. In 1842, he published his most famous paper, translated to English, entitled Concerning the Colored Light of Double Stars, which contained his first statement of the Doppler effect. Doppler's principle is the apparent change in frequency or wavelength of a wave when there is relative motion between the source of the waves and an observer. The perceived frequency is higher when the source of the wave is moving towards the observer and is lower during the recession. Here is an example of the Doppler effect that we are all familiar with. Let's imagine that you are standing on the street and you see an ambulance with a loud siren noise approaching you. As the ambulance gets closer to you, the sound wave frequency increases and the sound of the siren is higher pitched. But as the ambulance passes you and moves away, the sound wave frequency or pitch becomes lower. This apparent change in pitch or frequency of sound is known as the Doppler effect or shift. It is noteworthy that the Doppler effect is valid for all types of waves, for example, gamma, ultraviolet, light, and sound, where there is relative motion. With this background, we will now review color and power Doppler flow mapping in fetal cardiac examination. Through the next 5 lectures of this YouTube series, we will discuss the value of this modality, its settings and appearance, color Doppler of fetal cardiac views, and finally, the combination of color and power Doppler with Fine in examining the fetal heart. This is also known as color Doppler Fine, or commercially as 5D heart color. This is part 1, where we will review the value of color Doppler flow mapping in fetal cardiac examinations and why this should be performed. This will be supported by many illustrative fetal case examples. First, what is color and power Doppler? Here we will provide a brief overview, but we'll discuss these modalities in more detail in the second presentation on color Doppler settings. Color Doppler flow mapping is the real-time display of 2-dimensional flow patterns superimposed on cross-sectional pulse echo images of anatomical structures. Here is a 4-chamber view, and normal diastolic flow through the mitral and tricuspid valves into the ventricles is shown in red color. In contrast to color Doppler, power Doppler sonography analyzes the intensity or amplitude of Doppler signals instead of their frequency shift. Therefore, flow is represented regardless of the direction. Here is an example of the aortic arch with power Doppler applied. Using power Doppler as an adjunct to color Doppler can further delineate and define smaller vascular structures and low flow velocities, such as the pulmonary and systemic veins. Bidirectional power Doppler is a highly sensitive Doppler technology that utilizes both phase, directional, and amplitude, intensity, data to ensure vascular documentation. This example demonstrates both the aortic and ductal arches using S-Flow, which is found on Samsung machines. Now let's get to the main subject of this presentation. Color Doppler flow mapping is a valuable and integral component of fetal cardiac examination, and there are 7 reasons why this is the case. First, color Doppler allows identification of cardiac structures and vasculature, as well as the pattern and direction of blood flow throughout the heart. It also directs spectral Doppler interrogation of the fetal circulation, such as the ductus venosus. In the normal fetus, color Doppler reduces scanning time, which allows rapid assessment of the relationship and patency of cardiac structures. It also facilitates recognition of normal and abnormal cardiac anatomy when the two-dimensional image resolution is suboptimal. Finally, color Doppler may be especially helpful at earlier gestational ages. Finally, color Doppler may be a valuable tool when evaluating fetal cardiac anatomy in obese patients. Let's now review some case examples. The first showing how color Doppler allows identification of cardiac structures and vasculature. In this sagittal view, the normal azygous vein, shown by the black arrow, is clearly identified on color Doppler imaging. The azygous vein transports deoxygenated blood from the thorax and abdomen into the superior vena cava. It courses up the right side of the spine, draining into the superior vena cava, and forms the azygous arch. In the video, because the azygous vein drains into the superior vena cava, flow is represented in red towards the transducer. In the next case, this is a video clip of the fetal upper mediastinum showing the 3 vessels and trachea view. As the scan moves cranially, there appears to be a horizontal vessel draining into the superior vena cava and is suspected to be the left brachiocephalic vein, a normal fetal structure. This vein has been reported to be significantly dilated in the presence of supracardiac total anomalous pulmonary venous connection. This is a pathologic specimen of the fetal mediastinum. The pulmonary artery, transverse aortic arch, superior vena cava, and trachea are identified by the white arrows. The left brachiocephalic vein, shown here in red, drains into the superior vena cava. Notice that the left brachiocephalic vein is slightly cranial and anterior to the transverse aortic arch, which is shown in blue. Now, when color Doppler is applied, the pulmonary artery and transverse aortic arch have a blue Doppler signal away from the transducer, while the left brachiocephalic vein has a red signal towards the transducer, draining into the superior vena cava. Therefore, color Doppler is very helpful in confirming that this vessel is the left brachiocephalic vein. Color Doppler flow mapping also allows identification of the pattern and direction of blood flow throughout the fetal heart. Here is the 4-chamber view with normal diastolic flow into the ventricles, as shown in red color. Both the pattern and direction of blood flow are visible. Notice there is similar filling of both ventricular chambers. In this example, there is normal antegrade color Doppler flow through the left ventricular outflow tract, represented in blue, away from the transducer. Normal color flow through both the mitral and tricuspid valves is also shown in red towards the transducer. Finally, in this short axis view of the great vessels, color Doppler shows a normal pattern and direction of blood flow through the main pulmonary artery, which bifurcates into the ductus arteriosus and the right pulmonary artery. There is normal color flow in blue away from the transducer through these structures. Color Doppler can also be used to direct spectral Doppler interrogation of the fetal circulation. A wonderful example is applying this to the fetal ductus venosus. Here's a diagram of the fetal circulation. The ductus venosus is a trumpet-shaped fetal vessel within the liver that connects the intra-abdominal portion of the umbilical vein with the most upper part of the inferior vena cava. Importantly, the ductus venosus allows oxygen-rich blood to travel across the foraminal valley into the left side of the fetal heart, thereby bringing oxygen to the fetal heart and brain. Here is a different drawing depicting the vasculature of the fetal upper abdomen in an axial view. Notice the ductus venosus connecting to the umbilical vein. In this parasagittal plane of the fetal abdomen, the umbilical vein is easily seen. Although the ductus venosus is suspected to be within the red circle area, its specific location is not definitive due to the small size of this vessel. So, this is when color Doppler is invaluable in determining the location of the ductus venosus. The trumpet shape of the ductus venosus in combination with the venous pressure gradient increases the velocity of blood flow several-fold. This allows the ductus venosus to be recognized on color Doppler imaging. The left image is a sonographic axial plane of the upper abdomen, and the ductus venosus shows aliasing on color Doppler, an important feature that helps in its identification. This is also evident in the parasagittal plane image. Aliasing is identified by pixels of red and blue immediately adjacent to each other in a vessel and is useful to detect areas of increased flow. It is noteworthy that aliasing does not occur with power Doppler since it does not display velocity or direction of flow. Now that the ductus venosus has been identified using color Doppler, the sample volume or gate can be placed in the correct location to provide the spectral Doppler velocimetry waveform as shown. Such waveform normally has forward flow throughout the entire cardiac cycle with a characteristic triphasic pulsatile pattern. Therefore, we have shown a clear example of the value of color Doppler in directing spectral Doppler interrogation of a fetal vessel. Another illustrative example is performing spectral Doppler of the pulmonary veins. These veins drain blood from the lungs and enter the posterior wall of the left atrium. In both cases shown here, the pulmonary veins are identified at the level of the four-chamber view by the white arrows. Although the pulmonary veins can be identified on grayscale, as just shown, color Doppler is optimal and very informative since it depicts the direction of flow. Notice the flow represented in red color towards the transducer since pulmonary venous flow is entering the left atrium. Power Doppler can also nicely identify the pulmonary veins, although it has the disadvantage of not providing information about the direction of flow. Now that the pulmonary vein has been identified using color Doppler, the sample volume can be placed correctly in the vein to provide the normal pulsatile Doppler velocimetry waveform as shown. Notice that for this example, the waveform appears below the baseline, indicating that blood flow is moving away from the transducer. Indeed, flow through the pulmonary vein is represented in blue color. Color Doppler is also valuable in fetal cardiac examinations since it reduces scanning time. This is because in the normal fetus, color Doppler allows rapid assessment of the relationship and patency of cardiac structures. Color Doppler also facilitates recognition of anatomy when the two-dimensional image is suboptimal. Here's an example. This is a fetus at 39 gestational weeks in which the heart is suboptimally visualized on two-dimensional imaging. However, by applying color Doppler, diastolic flow through the mitral and tricuspid valves with filling of the ventricles is nicely shown in red towards the transducer. In addition, flow through the outflow tract from the left ventricle to the aorta is represented in blue, away from the transducer. Therefore, although the two-dimensional imaging is suboptimal, color Doppler facilitates recognition of some important cardiac anatomy. Here is a different example. Using 4D sonography with STIC, or spatiotemporal image correlation technology, a fetal cardiac volume dataset was acquired in combination with color Doppler. The STIC volume is analyzed using color Doppler fine. As shown here, the ductal arch, aortic arch, and superior vena cava are suboptimally seen on grayscale. However, once the color Doppler display is activated, these structures are more easily recognized. Look at the white arrow. Notice that the superior vena cava flow is represented in red towards the transducer as it enters the right atrium. At earlier gestational ages, visualizing cardiac structures can be suboptimal due to the small size of the fetal heart. Therefore, color Doppler flow is especially helpful at these early gestations, since it can depict blood flow across small structures. For safety reasons, color Doppler at early gestations should be used mainly to screen the 4-chamber and 3 vessels and trachea views. Here is a fetus at 13 weeks of gestation in which the sonologist starts at the 4-chamber view and then sweeps cranially towards the 3 vessels and trachea view. On color Doppler, 2 separate blood inflows into the ventricles are seen in red during diastole. In the 3 vessels and trachea view, antegrade flow during systole is shown in blue in the main pulmonary trunk and transverse aortic arch. Therefore, even at 13 weeks, color Doppler has been helpful in depicting 2 very important cardiac views. Here is another fetus at 13.5 weeks of gestation in which power Doppler nicely depicts the aortic arch in the sagittal plane. Color Doppler may also be a valuable tool to evaluate fetal cardiac anatomy in overweight or obese patients. This is because investigators have reported that the sonographic visualization of fetal anatomy, such as the heart, is adversely affected by the presence and degree of maternal obesity. For example, Hendler and colleagues conducted a study to examine the impact of maternal obesity on the rate of suboptimal ultrasound visualization of fetal anatomy, including the heart. Patients were classified into 4 groups based on their body mass index or BMI: normal weight, class 1 obesity, class 2 obesity, and class 3 obesity. The median gestational age of the study population was 19 weeks. In patients with normal weight, the suboptimal visualization rate of the fetal heart was 19%. When examining all obese women, the rate of suboptimal visualization of the fetal heart was significantly higher for this group at 37% compared to normal weight women at 19%. After further classifying the obese population, the authors reported an increased severity of obesity to be associated with significantly increased suboptimal visualization rates of the fetal heart. Normal weight 19%, obese class 1 30%, class 2 39%, and class 3 49%. In other words, with each advancing category of maternal obesity, there is a progressive increase in the rate of suboptimal visualization of the fetal heart. Therefore, in these cases, color Doppler imaging may be a valuable tool, particularly to demonstrate normal atrioventricular and ventriculo-arterial connections. Here is a two-dimensional scan of an obese patient in which the fetal heart cannot be properly assessed due to poor acoustic windows. So this would be a case in which color Doppler should be applied to facilitate recognition of at least some cardiac anatomy. Now, to summarize thus far, it is clear that color Doppler is valuable when performing fetal cardiac examinations. But an important question is, should color Doppler be performed in all fetal cardiac exams? The answer depends on the type of examination. When performing fetal echocardiography, for example, professional organizations, such as the ones shown here, require the routine application of color Doppler. But when performing a fetal screening sonographic exam, should color Doppler be performed? According to some experts, the answer is yes. Color Doppler should be employed routinely in fetal cardiac screening. The reason is that this will increase the accuracy as well as the speed of examinations. What does ISUOG say? In 2023, ISUOG published updated practice guidelines providing recommendations for low-risk fetal cardiac ultrasound screening during the second trimester. The guidelines encourage the use of color Doppler ultrasound in routine screening, but do not state that this is mandatory. Our view is that when imaging the fetal heart, routinely applying color Doppler is highly recommended, and we hope that these presentations will help you and provide useful information for your clinical practice. Now, the next topic to review is the value of color Doppler when imaging fetuses with congenital heart disease. In such fetuses, color Doppler sonography is essential to identify and characterize abnormal cardiac anatomy, abnormal flow patterns disturbances, and abnormal cardiac function. In addition, both the accuracy and prenatal detection of congenital heart disease improves by applying color Doppler flow mapping, especially with complex cardiac defects. Let's now look at some examples of color Doppler in identifying and characterizing abnormal fetal cardiac anatomy. A ventricular septal defect is an opening in the ventricular septum in which there is a hemodynamic communication between the ventricles. Small ventricular septal defects are often not identified prenatally. However, when using color Doppler, they may be detected occasionally. In the left image, there is a muscular ventricular septal defect located near the cardiac apex. Color flow is seen shunting across this defect. In the right image, color flow also identifies the muscular ventricular septal defect, shown by the arrow. Here is a case in which a ventricular septal defect is suspected, along with an overriding aorta. When color Doppler is activated, this is confirmed. Blood shunts across the ventricular septal defect and fills the overriding aorta from both ventricles. Here is another fetal case. On the left, a normal aortic arch with color flow in red towards the transducer is shown. The arteries, which branch off the aortic arch, are also visible in blue color. In comparison, color Doppler of the coarctation clearly shows narrowing of the transverse portion of the arch, along with turbulent color flow. Color Doppler can also identify and characterize abnormal flow patterns or disturbances. For example, this is a case of tetralogy of Fallot with absent pulmonic valve, in which there is severe dilation of the main and branch pulmonary arteries. This is a rare cardiac defect associated with an absent, dysplastic, or rudimentary pulmonic valve leaflets. This condition is associated with severe pulmonary insufficiency, and this is documented well using color Doppler imaging. Notice that there is aliasing of color, which is a sign of high velocity. This is also confirmed on pulse Doppler, which shows high velocities across the pulmonary valve with severe regurgitation. Here is another case. The aortic isthmus is the narrowest part of the aortic arch and is located between the origin of the left subclavian artery and connection of the ductus arteriosus to the descending aorta. The left image shows normal color Doppler flow through the aortic arch and isthmus. The flow is represented in blue, away from the transducer. Normally, only forward flow is seen through the aortic isthmus during the cardiac cycle. However, on the right, this fetus at 30 gestational weeks was affected with growth restriction due to placental insufficiency. Doppler velocimetry of the umbilical artery, middle cerebral artery, and ductus venosus were all abnormal. Notice that there is reversed color flow in red through the aortic isthmus during diastole. To confirm this, the 3 vessels and trachea view was also examined. Again, reversal of blood flow is visualized in the aortic isthmus during diastole. This finding indicates redistribution of the fetal circulation and that the fetus has problems maintaining cerebral oxygenation. When pulse Doppler is applied to the aortic isthmus, the waveform confirms reversed flow during diastole. Let's now review examples of how color Doppler can identify and characterize abnormal fetal cardiac function. Here's a fetus at 24 weeks of gestation. There is a very dilated right atrium and cardiomegaly in the setting of pulmonary atresia. When color Doppler is applied, significant tricuspid regurgitation is seen in blue, demonstrating the value of this modality for this case. Here is a different fetus affected with abnormal cardiac function due to Epstein anomaly. In this condition, the septal and posterior tricuspid valve leaflets are displaced inferiorly from the valve annulus towards the cardiac apex. Notice that there is cardiomegaly and that the right atrium is enlarged. With Epstein anomaly, the tricuspid leaflets adhere to the ventricular wall to a variable degree, contributing to regurgitation. Color Doppler imaging confirms that this is the case. Here is a different case with Epstein anomaly at 16 weeks of gestation. Again, the tricuspid valve leaflets are displaced inferiorly from the valve annulus towards the cardiac apex. Cardiomegaly is present, as well as an enlarged right atrium. Color Doppler shows severe tricuspid regurgitation into the right atrium. When pulse Doppler is applied, tricuspid regurgitation is visualized throughout systole. Notice that the peak velocity is greater than 200 centimeters per second. Specifically, the velocity is greater than 240 centimeters per second. Color Doppler also improves the accuracy and prenatal detection of congenital heart disease, especially with complex cardiac defects. The left video shows a normal pulmonary valve with appropriate leaflet excursion. However, the right video shows a different fetus at 29 gestational weeks in which the pulmonary valve is suspected to be thickened. Moreover, there may be post-valvular dilation of the pulmonary artery. Therefore, pulmonary stenosis is suspected. In this condition, there is an obstruction to pulmonary arterial blood flow. When there is mild to moderate pulmonary stenosis, prenatal sonographic findings can be subtle and easily missed. It is best to apply color Doppler to improve the accuracy and detection of this condition. Color Doppler depicts high velocities across the stenotic pulmonary valve, which is recognized by turbulent flow and color aliasing. Therefore, color Doppler has confirmed the suspected diagnosis. Moreover, pulse Doppler applied to the pulmonary valve also demonstrates high flow velocities at 185 centimeters per second. Here is a different case. As the name states, truncus arteriosus is characterized by a single arterial trunk arising from the base of the heart. The left image shows a ventricular septal defect and single great vessel which overrides the septal defect. Truncus arteriosus is suspected. When color Doppler is applied, antegrade flow in blue into the common arterial trunk is seen, along with regurgitation in red across the truncal valve due to its dysplastic nature. This is another case which demonstrates the value of color Doppler in improving the accuracy and prenatal detection of congenital heart disease. Both fetuses shown here are suspected to have hypoplastic left heart. In this condition, there are varying degrees of a small left ventricle with an atretic or hypoplastic mitral valve and underdeveloped left ventricular outflow tract. In the right video, notice that the left ventricle is very tiny and barely seen, while the right ventricle is clearly visualized. When color Doppler is applied, there is antegrade flow through the tricuspid valve in red color with a flash of regurgitation in blue color. There is absent color flow across the mitral valve, shown by the red arrow. When examining the arches, the ductal arch shows a dilated pulmonary artery, while the aortic arch is clearly hypoplastic. The video shows both the ductal and aortic arches. The survival of fetuses with hypoplastic left heart depends on blood flowing from the right ventricle through the ductus arteriosus into the descending aorta. Retrograde flow to the aortic root is essentially supplied by the pulmonary artery through the ductus arteriosus. Therefore, the coronary and cerebral circulations are supplied by retrograde flow. Color Doppler demonstrates this physiology. Notice that there is normal antegrade flow during systole within the pulmonary artery and ductal arch. The color flow is represented in red towards the transducer. However, in contrast, the aortic arch shows reversed or retrograde flow in blue color across the aortic isthmus, transverse aortic arch, and to the aortic root. Notice that the head vessels show red color flow since the flow is correctly going towards the transducer. Here is a three-dimensional sonographic image showing both the ductus arteriosus and aortic arch for this case. Notice that there is opposite color flow, red for the ductus arteriosus and blue, or reverse flow, through the transverse aortic arch. Here is a different fetus with hypoplastic left heart. The aortic arch is hypoplastic, and there is again reversed color flow across the transverse aortic arch to the aortic root, this time in red color. In a normal fetus, the flow should be away from the transducer in blue color. In conclusion, Doppler's principle is the apparent change in frequency or wavelength of a wave when there is relative motion between the source of waves and an observer. We have reviewed the definitions of color, power, and bidirectional power Doppler. Color Doppler allows identification of cardiac structures and vasculature. It identifies the pattern and direction of blood flow throughout the heart and directs spectral Doppler interrogation of the fetal circulation. In the normal fetus, color Doppler reduces scanning time. This is because it allows rapid assessment of the relationship and patency of cardiac structures. Color Doppler also facilitates recognition of normal and abnormal cardiac anatomy when the two-dimensional image resolution is suboptimal. Finally, color Doppler may be especially helpful at earlier gestational ages. In general, professional organizations require the routine application of color Doppler in fetal echocardiography. In fetal cardiac screening, some experts believe color Doppler should be employed routinely, while others encourage its use. In fetuses with congenital heart disease, color Doppler sonography is essential to identify and characterize abnormal cardiac anatomy, abnormal flow patterns and disturbances, and abnormal cardiac function. In addition, both the accuracy and prenatal detection of congenital heart disease improves by applying color Doppler flow mapping, especially with complex cardiac defects. Thank you very much for your attention.
you.